Recording will be start in 3, 2, 1. Please start, sir.
Good evening, sir. Dr. Himanshu, are you there?
Yes, yes.
Yes. Sir, Dr. Himanshu is there from our medical team. I would like to just hand over the meeting to Dr. Himanshu and further meeting will start, sir. Thank you.
Firstly, welcome you all for this Bare Eyesight meeting. And I'm trying to able to switch on my camera, but there is some issue. Nevertheless, so today we have a talk with two speakers and a session which will be moderated by the chairperson, Dr. S.N. Jha, sir, and who is the chairperson of Ophthalmology Department from Sir Gangaram Hospital. And our first speaker for today will be Dr. Anil Solanki, who is also an associate consultant from Sir Gangaram Hospital. And he'll be speaking on evaluating the need for change, evidence, and insights on anti-VEGF therapies. So it will be a talk of 15 minutes followed by a 5-minute discussion. And the second talk will be by Dr. Prashant Jain. Dr. Prashant Jain is a senior consultant based at Eye Care Hospital, Noida. And he will be speaking on case-based insight, aflibercept in managing DME, wet AMD, and PCV. And again, followed by 5 minutes of discussion. And at the end, I would request Dr. S.N. Jha, sir, for a vote of thanks of 5 minutes. With that, I'll like to hand over the session to Dr. Jha, sir. Over to you, sir.
Good evening, everyone. It's a wonderful evening, very cool breeze outside, though we have to be inside for your meeting. And this is, of course, the anti-VEGFs are drugs for the new incumbents in ophthalmology. They take it very natural that they see the patient and advise anti-VEGF treatment. But we have seen the time when we used to watch these patients to go blind in front of our eyes from 6 by 6 to counting fingers. So these are the great contribution by the industry, by the scientists, and of course later by the clinicians who carried out this study to change the life of these people, which the younger generation will not realize what these people underwent. Now we have, I know few professionals who are able to conduct and carry on their routine work because of these drugs. Otherwise, they would have gone out of circulation because of the disease that what they have. So actually, anti-VEGFs basically, of course, started with paclitaxel sodium, which because of the lower spectrum of activity went out of circulation very fast. And ranibizumab ruled the sky for a long time. Avastin, of course, bevacizumab is a cheaper version of that. Of course, due to some research hiccups, this drug didn't come before ranibizumab, which of course we came to know later about this. So the ranibizumab did change the whole scenario. Before that, we used to think in terms of preserving or reducing the loss of vision. We never thought of increasing the vision. So ranibizumab brought about that change. This was a welcome change. And the cost was, of course, forbidding for developing nations, which subsequently they brought it down. And now, of course, the Indian manufacturers have come in a big way to make it very cheap. But the problem with our population is that a very significant number of disease is PCV, and which, because of lack of the OCTA and ICG, we are not able to diagnose as such, and mostly we label them at neovascular AMD. And these are the patients who didn't do that well with the ranibizumab. Aflibercept was something real, like a fresh breeze of air for these patients. In the beginning, we were skeptical because, again, the price was a bit too high. They came out with a very, very patient-friendly program, which, of course, for definite reasons, they have been discontinued. But this is a drug which brought about a big change in the PCV results. And instead of doing lasers, and of course, some of them used to land up with surgeries, this drug has brought a big change in their life, and the number of injections definitely has gone down. Of course, I think possibly they are coming with a high dose drug, which might, if it say doesn't do any side effects, will be a welcome change. Maybe we'll cut down to the frequency to 6 months. The problem with anti-VEGF is repeated injections. So any effect to that effect that the number of injections could be cut down is a big relief for the patient, for the clinicians as well. So we are looking forward to the introduction of that 8 milligram also in future. For the time being, we'll be discussing about these effect of anti-VEGFs and the insight perspective by, we have two very young budding retinal surgeons, Dr. Prashant Jain and Dr. Anil Solanki. They will give you insight. And never forget that these are the drugs which brought about a big change in ophthalmology practice for both for the clinicians and for the patients. Thank you very much. I think now I will request Dr. Anil Solanki to start his talk.
Thank you, sir. I am sharing my screen. Is it visible?
Yeah, it is visible, but not in the slide mode presentation. Yeah, it is visible now. Okay. Yeah.
Okay. Good evening, everyone. I will be talking about evaluating the need of change evidence and insight on anti-VEGF therapies. As respected Jha sir has beautifully highlighted that initially there was no treatment. Now we have plethora of molecules starting from bevacizumab till the latest one, faricimab. And all these molecules, they inhibit the new vessels leakage and fluid and help in improving the vision. But in real world setting, there are significant gap and challenges which we encounter in achieving these goals. So we all know that what are the challenges for treatment of AMD with anti-VEGF. There is significant inter-individual differences in response to the anti-VEGF agents, and now we have multiple anti-VEGF agents. So which one to use for which patient is the problem. And there are a lot of variables like patient age, lesions characteristics, lesion duration, their baseline visual acuity, and their genetic makeup. All these things affect the response. So now how do you classify the response? Whether the response is optimal or there is no response. For that, there are basically two kinds of response. One is primary response when you keep on injecting monthly for 3 months and you see the response after a month after 3 injections. And secondary response is after 4th visit. Basically, you have injected 3 injections and then you see the result. That is your primary response. And after that, whatever is the response is your secondary response. And usually secondary response, it doesn't mirror the primary response. So it is not, if the primary response is good, secondary response is going to be good. That is not the case. And if the visual acuity at the presentation is good, then measuring the response in form of gain in letter is futile. So when you want to assess the effect of anti-VEGF, we have to take two factors. One is gain in visual acuity and second is change in morphology on OCT. So if we divide the response, it can be anatomical, that is change in morphology, and functional, that is gain in visual acuity. So we divided the response into good, partial, poor, and non-response. So when is the response good? When you do the OCT after giving the injection, 3 monthly injection and the 4th visit, and if you see there is no subretinal fluid, though no intraretinal fluid, no intraretinal cyst, and there is reduction in central retinal thickness more than 75% of the baseline value, then this response is morphologically good. And from functional point of view, there should be a gain of at least 5 letters on ETDRS. But if the vision is good, especially at the baseline, if it is around 70, so it doesn't go above 70. The maximum ETDRS is 70 letters. So you can't rely on the functional factor in the good response. The response is partial if the gain is 25 to 75% in the central retinal thickness and your subretinal fluid, intraretinal fluid, and intraretinal cyst, they are persistent or the new spaces are emerging, then the response is partial. And visual acuity gain is 1 to 5 letters from the baseline. Response is poor if the central retinal thickness decreases by only 25% and your subretinal fluid, intraretinal fluid, and all these things are persistent. And then there's no response when there is no decrease in the thickness as well as there is increase in thickness or there is new subretinal fluid, intraretinal fluid, and the vision has deteriorated. The change in letters is -5. Basically, there is loss of 5 letters. So now we have defined the response as in morphology as well as function. Now, as we have new anti-VEGF agents are coming, so whether it is a hope or hype, let's see with the help of few studies. So these are real world studies in which the patients were shifted from, those who are getting the aflibercept, they were shifted to faricimab injection. So this is at Japan. Mukai et al. Did the study. Baseline equity was 65 in US, Truckee in UK, Moorfields, and again in US, Fartina. All these studies, if you see these patients, when they are switched, there was gain of 2.2 letter in Truckee. There was gain of minus 0.1 letter, 0.3 letter. Still, there is some gain, but whether that gain is significant or not, we will see in the further slides. But if the patient is treatment naive, you can see there is gain of plus 4 letters. So the response is optimal. This is good gain in this Truckee study. So when we get a new molecule, we try to shift from the old molecule to the new molecule. But we should have such studies which can tell us whether this is of any benefit or not. So these studies are showing there is some benefit in some studies, like 2.2 here, 0.3 here. Similarly, in Japan, there was a study by Kotoka et al. From baseline to 6 months, 60% discontinued faricimab treatment. Basically, those patients were 130 eyes were early treated with aflibercept. They were switched to faricimab on quarterly, 4 quarterly, and then 8 quarterly interval. But the response was not good. 92% discontinued due to insufficient efficacy of the faricimab, and 73 switched back to the aflibercept. In this study, there was no visual acuity change. The central retinal thickness change was minus 17, and majority of the patients were not able to go beyond 8 weeks interval. Similarly, in Japan, Kisi et al. Did the study aflibercept to faricimab with treat and extend regimen. In the same, there was no change in the BCVA, CCT, central thickness didn't change. More than 70% has interval was less than 8 weeks. So in this study, Hara et al. Directly compared aflibercept with faricimab. And here you can see at month 1, month 2, and month 3, the visual acuity gain is plus 3, plus 4, plus 5 with aflibercept. But with faricimab, the gain was 0.5, 1, and 1. This gain will come in the poor response, wherein this plus 5, it is a good response. So if we compare directly aflibercept with faricimab, in this study it was compared, and we can see that aflibercept is superior from vision point of view. But the thickness, if we compare with both aflibercept as well as faricimab, there was minus 14 and minus 24 micrometer decrease. So it was more with the faricimab, but from vision gain point of view, it was better with aflibercept. So those were for the AMD. If we see in the DME also, if we switch from from aflibercept to the faricimab, the gain is not much, but they were saying that you can increase the interval. So after even 5th and 6th injection, the Q8, basically 8-week interval between injection was in 47% patient, 8-week to 12-week interval was in 46%, and 12-week, more than 12-week interval was achieved in only 6% of the patient. So one thing which they highlighted, that you can increase the interval with faricimab with the same response. So these are the statistics seen by the Belli et al. So this was a very interesting study. Basically, what it did, it said when we are giving, the criteria for switching is if you are giving injection and there is no response. So after 3 injection, you think now we should change the molecule. So what they did, they take the patient from CAT trial and DRCR trial and observe, because in that there was no criteria of switching. So patients were getting monthly injection. But in those patients, those who were not improving, they saw that in case of AMD, after 3 months, those patients who fulfilled the criteria of switching, they still gained 3-line vision. Similarly, at 6-month interval, those who were not responding, they still gain 5 letters, that is 1 line. And similarly in diabetic also. So what this study highlighted, that whenever you are switching, you should not compare with that, you are giving 3 injection. After giving 3 injection, you have switched to another molecule and you are getting 2 letters, 3 letters, and you're thinking that, oh, this is very helpful. You should keep one, comparative arm on the same molecule and switch the other arm and then compare. The control group should be maintained on the original agent. Then only you can ascertain whether the switching helped or there was some systemic parameters which patient control. Because of that, there is gain in the vision. So this study very beautifully highlighted that there should always be an arm. So in the previous study, we saw that there was gain of 2.2 letter or 0.8 letter. So that should be compared with the original molecule also in the control group. So could targeting, as highlighted by those molecules, could targeting the additional pathway beyond the VEGF pathway is beneficial? So there are certain studies like in this aflibercept plus nivolumab. This was a study. There was 2 studies, Onyx and Ruby. Onyx for AMD and Ruby for DME. They compared the aflibercept along with a molecule nivolumab, which is basically anti-Ang2. So it act against the angiotensin 2 receptor. So there were 4 arms with this 3 milligram, 6 milligram, and this is the light blue color is aflibercept monotherapy with 2 milligram 8 weekly and 12 weekly. Now you can see in AMD, this light blue color are monotherapy and dark one are for combination with Ang2. As you can clearly see, there is no added advantage of adding a Ang2 along with aflibercept in case of AMD as well as DME. So it was not statistically significant. Now comes to the faricimab. So faricimab claims that it has one arm that is exactly similar to the ranibizumab, and the other arm is Ang2 arm. So there was another, the previous study which I just told you about, it compared Ang2 with this is the same molecule, but it is a single molecule. In that study, we compared 2 molecules together. So faricimab is VEGF-A inhibitor as well as Ang2 inhibitor. So in this, there was 2 studies, Tenaya and Lucent for AMD and Yosemite and Rhine for DME. In this, they were compared, the study was that faricimab versus aflibercept, whether it is superior or whether it is non-inferior in the visual outcome. So it was as good as aflibercept. But there is another clinical trial, Avenue clinical trial, which compared the plasma level of Ang2 concentration at baseline and 4 weeks after the injection. So what they did, they injected ranibizumab and they injected faricimab and they compared the plasma Ang2 level. And to their surprise, the Ang2 level inhibition was similar between both the agents. Whereas in case of ranibizumab, there is no Ang2 inhibitor. Still, the Ang2 level were similar in both the groups. So what is the reason why the Ang2 level is falling down? So even in US FDA approval for faricimab, they clearly stated that the VEGF antigen binding Fab is identical to ranibizumab, but the contribution of Ang2 inhibition to the treatment effect and clinical response for AMD and DME has yet to be established. This was at the time of FDA approval. So as I was telling you, if we are not directly targeting the Ang2, how come it is coming at the same level with ranibizumab? So there was an experimental study which evaluated the aflibercept, which showed that when you are inhibiting the VEGF, it is basically secondarily inhibiting the Ang2. So this study hypothesized that Ang2 may be expressed secondary to the primary insult of retinal vasculature by VEGF. So if you decrease the VEGF, Ang2 will come down on its own. So direct inhibition of Ang2 is not required. If you decrease VEGF, Ang2 will come down on its own. There is no need to directly target the Ang2 for added advantage. So with this information, VEGF receptor pathway remains the master regulator in retinal diseases. So there are two receptor, VEGF receptor 2 and VEGF receptor 1. So 2 binds to VEGF-A and 1 binds to VEGF-A as well as placental growth factor. So what is placental growth factor? It's a member of VEGF family. It is expressed by multiple cells under pathological condition. It binds to VEGF-1 receptor, not to the VEGF-2. So when there is binding of VEGF-A or placental growth factor to VEGF receptor 1 or 2, it causes inflammation, neovascularization, and retinal vascular leakage and edema. So both VEGF-A and placental growth factor are the key component of the inflammatory response cascade. So if you see here, the agents which are approved, which we have in our armamentarium is brolucizumab, faricimab, ranibizumab. All of these agents suppresses the, block the VEGF R2 receptor, but it has no effect on VEGF R1 receptor. The only agent which act on this is, along with that, is placental growth factor. So in summary, with aflibercept 2 milligram already targeting the key master regulator VEGF pathway, there may be limited potential or improvement in functional outcome for the patient. Increasing the molar dose of anti-VEGF agent may have the potential to offer patient more thorough extended VEGF suppression. So if aflibercept, as we see in the study, it has already set a high bar for other molecules to suppress the standard of care in terms of vision gain, durability, and safety profile across indication. Aflibercept target the key ligands, the VEGF pathway, the master regulator of the pathological angiogenesis. Targeting other pathway has till now not resulted in the improved patient outcome beyond aflibercept. Although data from Pulsar and Photon studies suggest that increasing the molar dose may increase, sustained disease control, and we can increase the interval of the injections. Thank you.
You're done with Dr. Anil?
Yes, sir.
Thank you very much for giving a very clear-cut idea of how the anti-VEGF works. And Dr. Himanshu, can you take questions? It will come by message or they can ask directly the participants. Hello?
Sir, they can unmute and ask directly. That is not an issue, sir.
Okay. So if there are any question, I think Dr. Anil will be very happy to answer your questions. So you are free to answer the questions. Dr. Anil, if they ask you anyone. It appears you have explained it very well. In the real world situation, only thing I will like to add, of course, it will go against the desire of our sponsors, that faricimab seems to work longer period in diabetic maculopathy. The fluid remains like absent dry for longer period as compared to other anti-VEGF agents. Of course, we don't have very, say, large number of patients, but this is one impression I got and from the faricimab use. Of course, aflibercept still at present is definitely ruling the scene for NMD, and that will continue for a while till then any new drug or new drug combination comes. So I think we can move to the next talk by Dr. Prashant Jain, who is a very, say, busy retinal practitioner in eye care and has graduated from very illustrious center, Aligarh, which used to be at one point of time the leading center of ophthalmology in India. So, Dr. Prashant Jain, you can start your talk.
Good evening, sir. Thanks for giving me this opportunity. So, are you able to see my slides?
Yes, we are able to see your slide. Yeah.
Okay. So, I'm sharing few cases, which is like a real world scenario with aflibercept, which I got in my practice. So the first case was my one of the initial cases where I have started the treatment naive patient on aflibercept. Before that scenario, generally I used to give either ranibizumab or bevacizumab, but this is one of my few cases where I have started giving Eylea in treatment naive patient. So it's a 48-year-old male who is a non-diabetic for 10 years. HbA1c was quite uncontrolled, and when patient presented to me in September 2022, the initial BCVA was 612 in right eye and 618 and 10 in left eye. So this was the clinical picture. You can see a lot of blood hemorrhages with cotton wool spots, and picture was similar in both eyes. So I did FFA. FFA, there were few CNP areas, one suspected NV in the left eye. Apart from that, it was severe NPDR type picture in right eye. So there was marked CME with SMD in both eyes, which was more in left eye. So I decided to give 3 loading dose of aflibercept in both eyes in this patient. And there was significant improvement after first loading dose itself, and I was quite thrilled. So this was the picture after 3 loading dose. BCVA improved to 6.6 and 6 in right eye and 6.12 and 8 in left eye. So after 3 loading dose, then I decided to give the fourth also because there was still fluid was there in the eye. But patient somehow was not interested in taking the fourth dose and he vanished. But he again came in 5th month for next follow-up with improvement in BCVA, definitely. It was 6.6 and 6. But there was minimal increase in CME in both eyes. So this was the picture. In January, when he presented to me in the 5th month, there was slight increase in CME. So I decided to give the anti-VEGF, and again he improved. Then I again injected this patient in Feb 2023, then April, June, September, December, and April 2024, and there was remarkable improvement on each follow-up visits. So this patient I saw in last in July 2025. At that time, this was the picture, and even on FFA there was a remarkable improvement in both eyes. So you can see the vanishing CNP areas, even that dot blood hemorrhages or leaking microaneurysm was decreasing. So there was 35 months follow-up with this patient till August 2025. I've seen him last. So till date, he took 9 aflibercept in each eye. So like evidence-based medicine or the studies which suggested, in first year he took 5 aflibercept in each eye, and afterward he was quite compliant, and second year he took only 2 aflibercept, and third year 2 aflibercept. There was marked improvement on FFA, and HbA1c has improved to 6.5, which was initial stage it was 11.2, and is maintaining BCVA of 6.9 and 6 in both eyes. So now I'm presenting the second case. So this case I'm presenting because patient in this case is super compliant and HbA1c was quite normal, well controlled diabetes. There was no history of any hypertension, and young male. So he presented to me with diminution of vision in both eye in 2022. BCVA was 636 in right eye and 636 in left eye. So this was the picture, clinical picture. You can see that NPDR like picture was there, severe NPDR. So I decided to do FFA and OCT in this patient, treatment naive patient. So this was the picture. There was quite NVs in right eye, and the similar picture was there in the left eye with lot of CNP areas and leaking aneurysm. It was marked CME with schisis-like picture in both eyes. This was the right eye, and there was similar picture in the left eye. So I decided to give first 3 loading dose. So after 3 loading dose, there was marked improvement. So after 3 loading dose, I decided to do the PRN basis treatment since it's a DME case. So in this patient, every 3 months, there was recurrence of fluid. So you can see, which I have highlighted in red one, that 3 month post injection in 2022, improvement of vision was there, 618 and 624 in the left eye. But after every 3 months, there's recurrence of fluid, and I was unable to maintain the difference between two injection by more than 3 months. So almost every 12 months, I was giving him aflibercept, and he was coming regularly on follow up. So this was the picture after many injection. Then I decided to switch to brolucizumab. I thought, let's try brolucizumab. Maybe I can increase the duration between two injection. So I injected brolucizumab in 2023, and surprisingly, after 2 months, the effect of brolucizumab vanished. So I decided, let's try one more brolucizumab, and I injected one more in this patient. So after giving second brolucizumab, again the fluid recurrence was there in the second month. So it was not going beyond 8 weeks. So in this patient, at this moment, I again decided to switch to aflibercept, and again the scenario was same, that after every 3 months I was giving aflibercept. So till 2024, I have given 6 aflibercept in both eyes and 2 brolucizumab in both eyes. And initial BCVA was 636. So after this much, the BCVA has improved to 69 and 6 in right eye and 612 and 8 in left eye. So this was the clinical picture. And at that point of time, there was initial days of faricimab. So I thought, let's try faricimab so that I can increase the duration between two injection to maybe 16 or 20 weeks as claimed by them. So this was the picture 6 week post first faricimab. There was remarkable improvement. But surprisingly, after 10th week, there was recurrence, which was 12 weeks in aflibercept. But again, I decided to give faricimab only. And again, after 10 weeks, there was recurrence. So it was not going beyond 10 weeks. So I thought, let's give aflibercept in right eye and faricimab in left eye. So again, aflibercept was going till 12 weeks, but there was recurrence in 10th week. But I decided to wait, and there was remarkable increase in CME when patient presented to me at 12 weeks in left eye. So I decided to give one more aflibercept in right eye and faricimab in left eye. And again, the scenario was same. So at this point of time, I decided, let's go back to aflibercept only. And now this patient, almost I'm injecting at 14th week. So from 12 week, I'm able to increase the duration between two injection to 14 week, but not beyond that with aflibercept. So this was the last picture. So it's a compliant patient. With me now, it's almost 40 months of follow-up, and he's maintaining a good visual acuity in right eye. Left eye, there was drill and everything. So vision is not that great. It's 618 and 8. So till date, he has taken 9 aflibercept, 2 brolucizumab, 2 faricimab in right eye, and 8 aflibercept, 2 broli, and 3 fari in left eye. It's left eye, not right. So finally, I shifted back to aflibercept as duration between two injection. I'm able to stretch between 13 to 14 weeks, which was only 8 weeks with brolucizumab and 10 weeks in faricimab. So now I'm presenting one of the case of PCV. So this patient I'm treating almost for 4 or 5 years. So she presented with me with diminution of vision in left eye for 1 month, and at that time the visual acuity was 6, 9, and 8 in left eye. And she is a old 82-year-old female, both eye pseudophakic, anti-segment was within normal limit. And this was the picture. So when I did the OCT, there was thumb-like polyp with DLS, SRF, and IRF. And this was the other sections. So I decided to do ICG, and there was extrafoveal polypoidal lesion, which was typical of IPCV. So since it was extrafoveal, I decided to laser it off. So first I gave him anti-VEGF, and I decided to do the focal laser of that polypoidal lesion. So I gave aflibercept in 2021 in left eye March, and this was response after 2 months of the aflibercept. So I decided to give one more aflibercept. There was shallow fluid in one section, and after 4 weeks, it was almost dry. So at that time, that pandemic started, and patient lost to follow up in pandemic, and came after 8 months when there was some relaxation in lockdown. So at that time, again, her BCVA was 6998, but there was remarkable fluid in the eye, and you are able to see that scar mark of the laser which I have done. So I gave her one Eylea, and on follow-up, I decided to do the ICGA because I don't know whether I will be able to do ICGA and then give injection. At that time, there was pandemic, so I decided first I will give Eylea, and then maybe on follow-up, if she is coming, then I will do the ICGA. So this was the picture when she presented to me after 3 weeks. This is the laser marks of the previous polypoidal lesion scar, and these are the section. So there was increase in PED size after giving the aflibercept, but there was a slight decrease in SRF. So this is the another section. So when I did the ICG again, there was new polypoidal lesion with hypocyanosis area around due to the PED. And these are the few other section. We can see laser marks of the previous one with DLS and SRF. So I gave one more Eylea in April 2021 after this ICGA, but due to second wave, patient was unable to come after 4 weeks, and next follow was after 6 weeks. So patient vision has dropped to 618 and 12, and there was increase in SRF with PED size, and we can see that trapezoid PED is there with DLS and SRF. You can see so that tall peak PED in the other section, and there was remarkable increase in SRF in the inferior section. So I decided to give one more Eylea, and after follow-up, after 4 weeks, BCV improved to 6, 9, and 6. So then this is the follow-up visit, but definitely SRF has decreased, but the size of PED is increasing even in other section, and only that SRF is decreasing in the subsequent section, but increase in PED size. So I decided to give one more Eylea, next follow-up after 4 weeks. Again, BCVA, she is maintaining 6, 9, and 6. And this time there is quite decrease in SRF with PED size. This is the another section, other section. This is the previous, and this is the follow-up section. So it was better than previous scan. Still disease activity was there. I injected one more Eylea. So she is a ECHS patient. There was no problem in getting the Eylea and everything. So after follow-up visit, again there was remarkable increase in PED size with SRF. And this is the another section. We can see even that early rip type picture at this section. So, but there was increase in tall peak PED, SRF, and again I decided to do the ICG, and the lesion was almost same, the similar picture which she presented to me in March. So, non-responding to Eylea, I decided let's try Paginex. Paginex was in the initial days, but due to that risk of vasculitis and everything, so patient opted for Eylea only, and I gave her one Eylea follow-up after 3 weeks. So there was decrease in size of the PED with SRF, but still SRF was there. So I gave one more Eylea follow-up again after 4 weeks. SRF was not going to dry state. The SRF was there. So I thought if Eylea is not working, so this time I again pushed patient to take Paginex, and she took one Paginex in November 2021. And next follow-up after 3 weeks, there was remarkable improvement in one of the section, but other section it was almost same. So I thought that Paginex is also not working in this patient. So I decided to give one more Paginex, but patient was not happy with the Paginex. She told me the visual improvement was more with Eylea and it was not with Paginex. And so I decided to switch back to Eylea, and I gave one more Eylea in December 2021. So this was the picture, increase in size of the PED, nose PED, even SRF has increased. So I thought I'm giving lot of aflibercept, so let's try different molecule. So I thought let's give a try to the ranibizumab, and I injected one ranibizumab in Feb 2022 in a desperate attempt to get something. So next follow-up after 3 weeks, there was increase in size of the PED with SRF. I did ICG again, same picture. So again, then I switched back to aflibercept. I again gave aflibercept in March 2022. And on follow-up visit, there was decrease in SRF. So I inject again. But when she presented to me in 1 month after the next injection, there was increase in SRF in the sections. So I decided to give Paginex again because there was no other option for me. And Eylea, aflibercept, even none of the molecule was working. So I injected again that Paginex. So this was the follow-up visit. And there was increase in SRF and no PED after Paginex this time. So Paginex was not at all working in this patient. So again, I switched to aflibercept. I was hopping between all the molecules. So on follow-up visit, there was minimal decrease in SRF, no PhD was same. So I inject again that aflibercept. But on follow-up visit, there was increase in SRF. So I was not happy because even after injecting the aflibercept, if the fluid was decreasing slowly, that would be a better scenario. But at this point of time, it was increasing. The SRF as well as PED was increasing in size. So this was last follow-up in December 2022. At that time, there was huge size of the PED with SRF. So patient at that time went to Bangalore to stay with her son, and she showed up there and took one Eylea there. And next follow-up, she came in Feb 2023 after 2 months, and there was lot of SRF with marked increase in PED size and IRF. So patient was not responding to Eylea. I decided to shift it to Paginex, but every time whenever I was giving Paginex, there was increase in SRF and PED size. So there was suboptimal response to Paginex. So I thought what to do next. So out of the blue, I thought why not try IVTA. So first I decided to give IVTA alone, but then I thought we can combine it like we do in most of my DME patient. So I decided to give Eylea plus IVTA in this patient. And surprisingly, this is the picture after 3 weeks of Eylea plus IVTA. There was almost flat PED with almost vanishing SRA, which was not going for almost 2 years. So this was the picture. The SRA was almost negligible. So and this is the picture that load of hard exudates after IVTA. And I did ICG, and surprisingly, the polypoidal lesion, which was not going for past 3 years, it completely vanished. So I was surprised. Then I decided to give second Eylea plus IVTA, and this is the 5th day picture post second Eylea plus IVTA. This is the 5th week picture. So this is the last follow-up which patient presented to me, and I gave her last injection in April 26. So after IVTA, which I gave her in 2023, patient, and I gave almost at that time 3 Eylea plus IVTA. After that, I am not giving IVTA, but yeah, whenever fluid is there, I am giving Eylea only. So patient took 3 Eylea in 2024. After that, last IVTA plus Eylea, and only 2 in 2025. And last injection I injected her in April 2026 only. So last follow-up, recently she came to me in May 2026. There was no polypoidal lesion on ICG. I repeated, and there was dry macula. So finally, after till date, she took 25 aflibercept, 5 Broly, 1 ranibizumab, and 1 bevacizumab. So in her case, surprisingly, IVTA worked well. And to my surprise, that polypoidal lesion vanished with the IVTA. I tried to find out the reason, but why that polypoidal lesion? I definitely can understand that inflammatory factor is there, and fluid can decrease after that IVTA response. But complete vanishing of that polypoidal lesion is quite surprising for me in this case. Thank you.
Thank you, Dr. Prashant Jain, for a wonderful demonstration of your perseverance and persistence and the patient's loyalty to you. It was really great to have followed that patient a long time. Any questions from the audience?
So may I ask?
Yeah.
Please.
One thing I wanted to highlight because there are a lot of residents have joined, that both the DME patient had HbA1c of 11, I think, in the starting, and when there was good response,
That
they
second
reached-
patient was 5.8 only.
Okay, it was 5 point. The first one was 11 and reached to 5.8. So the importance of systemic control is always there. So, Dr. Prashant, what investigation do you do? Systemic investigation at the start of a diabetic macular edema patient?
Generally, I write everything: HbA1c, CBC, KFT, lipid profile. Even lipid profile, if that triglyceride is high, and if I am seeing lot of hard exudates on my fundus examination, so if patient is not taking any medicine for triglyceride or anything, so I used to start that fenofibrate for myself, because I've seen if patient taking fenofibrate for long time, more than 6 months, that hard exudate used to decrease, and it helps a lot in that vanishing or decreasing the DME effect.
Right. So
Even KFT, if patient is on dialysis, then there will be more CME like picture, that SMD like picture will be there. So hypertension control, KFT control is one of the most important factor in this DME scenario.
So, in your PCV patient, what was your thinking for injecting IVTA or Ozurdex? What didn't come to your
Ozurdex, I've never injected in IPCV. So the only thing which clicked at that time to me, that before this Eylea scenario and everything, we used to do a lot of PDT. So at the time of the PDT, we were injecting IVTA also along with anti-VEGF. So to decrease that inflammation, because after PDT there can be a lot of inflammation. So I thought that it's safe. So if nothing is working, so let's try IVTA. I don't know why I've given IVTA and I'm not getting that conclusive evidence also. I've tried to search lot of papers and everything, but I'm not getting anything like this. Okay, why IVTA works in this case? But definitely that PDT, that whenever we were doing that combined PDT, I thought let's try IVTA in this case.
results were wonderful, and you injected 1 milligram.
Yeah, 1 milligram.
1 milligram. And was there any increase in IOP?
No. That's why
No.
I was seeing that patient regularly on initial visits.
Very-
Rajan, in second case, diabetes, you have a lot of new vessels. Did you
Yes,
do
sir.
laser?
Yes, sir. That I have done 3 sitting PRP.
Okay.
Generally, if NV is there, I never thought to give anti-VEGF and decrease that, because that is temporary. Whenever we are stopping anti-VEGF, that NV again will come. So in all my NV patient or CNP or NVD patient, I used to do that 3 to 4 sitting PRP. In this patient, I have done it.
Okay, great. So it was
Very well
wonderful.
documented cases, Dr. Prashant. Very nice.
Mhm.
Thank you.
So I think it was a great interaction, and we all have learned a lot from these two presentations. And if there is no further questions, I think I'll request the Bayer people to close the session, unless they have to say anything, something.
Thanks to both the speakers for bringing out the points, especially the cases from Dr. Prashant. They were wonderful. And
Himanshu, you're not audible.
hello.
The voice is not coming clearly.
Hello.
Yeah, better now. Better.
So I was saying, firstly, I'd like to thank both the speakers and for thoroughly covering the aspects, different aspects regarding the pathophysiology as well as the management set of using the aflibercept. And thank you to Dr. Prashant also for presenting different cases. And as you rightly said, a thorough case with 25 injections. It's very rare to see this long follow-up with any patient. So I would like to thank both of you again, and thank you, Dr. Jha, for wonderfully moderating the session as well as chairing the session. So if there are no questions with the from the audience, then maybe we can close the session. Tech team.